Well, good morning, everyone. Welcome to Alumni Weekend 2026. My name is Brian Komodo, PharmD from the class of 1981, and I'm proud to serve as a UC Regent and as a member of the UCSF Alumni Leadership. Alumni Weekend provides a special opportunity to see the new changes on the two campuses that we have, reconnect across schools and generations of alumni. It is also a time for us to engage with old classmates, meet new. Well, there's some that are here 50 years, celebrating their 50 years. Anyway, meet new and young alumni, and meet the new leadership and learn about the amazing new discoveries that continue to elevate UCSF's impact on the nation and the world. Each program and speaker featured this weekend was thoughtfully selected to reflect the excellence in research, clinical care, and education that defines UCSF and advances its mission every day. This opening session sets the tone for the weekend with a meaningful look at UCSF's latest achievements, scientific leadership, and strategic priorities. It is now my honor and pleasure to introduce Dr. Sam Hawgood, our Chancellor of UCSF, a distinguished academic leader, research professor, and pediatrician. Chancellor Hawgood has masterfully led UCSF since 2014. In an era where basic science and discoveries are being questioned and threatened, we have the perfect leader to skillfully defend and promote the groundbreaking technology and work being done at UCSF. So please welcome Chancellor Hawgood.
Thanks, Brian. Thank you, Brian, and thank you for your leadership on the Board of Regents. It's always great when I go to Regents to see a familiar and friendly face. Good morning and welcome everyone to Alumni Weekend 2026. It's great to see you all. I won't make Brian's rookie mistake and say any comment on how long you have been an alum, but it's great to see you all back. As Brian said, we have just an amazing lineup of speakers and sessions for you this year, and I'm excited to kick off the celebration by sharing a few highlights from our prior year. Now, as I watched the images on the screen just a few minutes ago, I was reminded that UCSF's mission doesn't just unfold on our campuses and in our hospitals and our clinics. It lives through all of you. As UCSF alumni, you carry our mission forward every day in clinics, in labs, in communities, and in the lives that you've touched over decades of care and discovery. And it's especially meaningful that we gather here at Mission Bay this weekend in a place where so much innovation begins. We've had many celebratory moments here at Mission Bay recently. We honored UC President Emeritus Michael Drake with a public plaza that is named for him at Mission Bay. Michael is a UCSF alum and longtime faculty member who has made significant contributions through the past 5 decades to both the University of California system and to UCSF, where he practiced for over 20 years. The university recently acquired 2 life science buildings. If you go outside this building and look as far towards the bay as you can, you'll see these 2 buildings that we've recently acquired that will help transform and shape the future of health professions education at UCSF. This strategic expansion will create urgently needed space for a new home for the UCSF School of Dentistry, a leading edge hub for interprofessional education and expanded research capacity. It will also significantly increase access to high-quality dental care for our community. At the heart of the investment is a bold reimagining of UCSF health professions education. The building held a biotech company in 409 Illinois Street, but it will soon be transformed into a modern center for instruction and learning, featuring a 60,000 square foot education center where students from dentistry, medicine, nursing, pharmacy, and physical therapy will learn together in high-tech simulation and team-based learning environments. This building will also hold the School of Medicine, a School of Dentistry, as I just mentioned. These will be forward-looking dental clinics designed for the future of oral health care. These clinics will incorporate digital dentistry, integrated primary and specialty care, team-based care models, and expanded capacity to serve Bay Area patients and beyond. The state-of-the-art clinical setting will enable UCSF dentists to lead and prepare graduates in an evolving healthcare landscape while delivering more efficient, accessible, and patient-centered dental care for our community. On another highlight of this last year, we recently received an unrestricted $100 million gift to fuel the UCSF Edward and Pearl Fine Memory and Aging Center on this campus. This generous philanthropic investment comes at a critical moment as neurodegenerative diseases such as Alzheimer's affect a growing number of people worldwide. It will create a lasting impact for our patients, their families, and the dedicated health professionals who care for them. This is the first gift in UCSF's history to name an entire division in a department, a distinction that speaks to its profound impact on our commitment to advancing brain health. It is the people who drive success every day at UCSF. Our educators, scientists, learners set in motion ideas that guide discoveries and define UCSF as a place of excellence and collaboration. I want to share a few examples of faculty members who have recently been recognized for extraordinary achievements. Christine Dillendorf, a professor and vice chair for research in the Department of Family and Community Medicine, was recently elected to the National Academy of Medicine, one of the highest honors in health science. Dr. Dillendorf's election honors her pioneering leadership to transform reproductive health systems towards a care that honors patients' values and choices. Professor Emerita Christine Majakowski was named a living legend by the Academy of Nursing. This honor recognizes nursing trailblazers who have made an indelible impact on the nursing profession. Dr. Majakowski has helped shape the field of oncology nursing and advance scientific understanding of pain and other debilitating symptoms in cancer patients. 1985 PharmD alum Sharon Yeomans, who I saw, there you are, Sharon, Executive Vice Dean and Professor in the Department of Clinical Pharmacy, has been named to the California Pharmacists Association Hall of Fame, while 2001 alum and volunteer faculty member and one of last year's Alumni Award winners, Maria Lopez, has been selected as the organization's 2026 Pharmacist of the Year. 2 Department of Physical Therapy faculty members received 2026-27 Innovations Funding for Education grants. Assistant clinical professors Mariano Welchler and Vincent Ann were awarded funding to introduce AI-enabled simulated patient encounters in the Doctor of Physical Therapy curriculum. I also want to share that Talmadge King, sitting here in the front row, who has served as Dean of the School of Medicine for the past 11 years and an incredible thought leader for me, is stepping down in June and will return to the faculty. I don't think you ever actually left the faculty, but You'll have a different office. I'm deeply grateful for his meaningful contributions and the significant transformation he has made in medical education, ensuring that UCSF graduates are equipped to lead in an increasingly complex healthcare landscape. Talmadge has left an enduring impact in his 30 years at UCSF. I hope that you will stay to hear insights from Dr. King and all of the deans in the session that immediately follows this. Now, the excellence that we see in our faculty is also reflected in our learners, with UCSF once again recognized as a top producing institute for Fulbright US scholars, our 9th time at the top since 2010. I'd like now to highlight just a few learners who are already shaping the future of science and healthcare. Alice Tang, a student in UCSF's Medical Scientist Training Program, was recently named to the Forbes magazine 2026 30 Under 30 list for science, using AI computational tools to understand and diagnose Alzheimer's and other complex diseases. Christopher Oroxo, a second-year UCSF medical student in orthopedic surgery and a member of the department's Socioeconomic Acculturalization Language Lab, was awarded the 2025 Short-Term Dean's Prize for his research on wide-awake hand surgeries. Work that is helping make surgical care more accessible and equitable for patients who prefer languages other than English. Ali Gomez Ojeda is a fourth-year UCSF Medical School in the San Joaquin Valley Prime Program, who was honored with the UC President's Award for Outstanding Leadership in Anti-Oppression and LGBTQ Health Education. And finally, the UCSF chapter of the Student National Dental Association was awarded the 2025 University of California President's Award for Outstanding Student Leadership for promoting diversity within the UCSF School of Dentistry and the greater dental profession. When our learners graduate, they carry forward a commitment to health equity, social justice, and excellence. And this year, that commitment is reflected in the extraordinary accomplishments of our alumni. We will be honoring 8 individuals at the Alumni Awards brunch tomorrow morning. Still, I'd like to highlight a few others who have been recognized this year for exemplary achievements in their fields. Jenny Chin Hansen, a 1971 nursing alum and a 2022 UCSF medal recipient, was selected to join a distinguished group of California healthcare leaders serving on the Future of Medi-Cal Commission. She was also inducted into the Continuing Care Hall of Fame. Brian Bast was honored with the 2025 Rappaport Award for a lifetime contribution as a physician. Brian is a 2000 School of Dentistry resident alum, chair of the School of Dentistry's Oral and Maxillofacial Surgery Program, and chief of OMFSS at UCSF Zuckerberg San Francisco General Hospital. And finally, Ruby Alva de Hickson, a 2024 alum of the Postmaster's Entry to the Doctor of Nursing Practice Pathway, received the 2025 President's Award from the National Association of Hispanic Nurses, the organization's highest honor. The award recognizes Ruby's advocacy and leadership, including her work to develop an immigration toolkit to safeguard patient rights. Tristan Storm, who earned a PharmD degree in 2021, has returned to UCSF to help educate new cohorts of pharmacy students while continuing to advocate for more inclusive, human-centered healthcare. His focus is on queer and trans health and the importance of holistic, interdisciplinary approaches to patient care. Now, these achievements and so many others by our alumni don't happen in isolation. They are made possible by the support that fuels the continuum of our work, from curiosity-driven discovery to care for our patients and communities. From October 2024 through September 2025, UCSF received $824 million from the National Institutes of Health, more than any other public institution in the country. The schools of medicine, pharmacy, and dentistry ranked first amongst their peer institutions. UCSF's success in attracting NIH funding is a testament to both the excellence of our researchers' work and the support of the constituents who back them along their way. As you're aware, NIH funding is absolutely indispensable to advancing medicine in the changing landscape that we face today. It took an extraordinary effort to achieve the milestone of the success last year. I'm grateful to our advocates in Congress on both sides of the aisle who championed efforts at the state and local level, and to each of you for your ongoing advocacy and support of medical research. I was in Washington yesterday, and we continue to face uncertainty in the current budget cycle. The financial headwinds, especially at the federal level, are real. Our response is to continue our commitment to our values, providing opportunities for all, and sustaining excellence in innovation. Philanthropy has always been important for the seed funding for our most high-risk, high-reward science. Now, more than ever, it is essential to enable our researchers to do the early work required for even more competitive federal funding. UCSF has recently launched an awareness campaign to help share the impact of our work and provide advocacy resources. Saving Lives with Science emphasizes the importance of federal funding to support our research and offers tools to connect with lawmakers, engage in policy change, and participate in advocacy efforts. UCSF's research enterprise remains incredibly strong, while the national funding environment is increasingly uncertain. Sustaining scientific progress depends on continued public support. You are amongst our most powerful advocates for research and discovery. Your trusted voices carry influence in your communities and on the national stage. I encourage you to check out the Saving Lives with Science flyer in your swag bag to learn how you can help ensure the critical discovery work we do at UCSF continues. To sustain our scientific work, we must also invest in what makes it possible: state-of-the-art infrastructure, modernized patient facilities, and innovative learning environments. There are construction cranes across UCSF sites all over the Bay Area, but they are particularly active at the moment on the Parnassus Heights campus as we build an academic medical center for the future of healthcare. Here's a glance at a recent milestone in the construction of the Barbara and Gerson Baker Research and Academic Building on Parnassus Heights.
This was a building that was literally designed by the scientists who are going to work in the building. It's a remarkable project. If you look at almost every major breakthrough, I mean those breakthroughs that are logarithmically impactful, that are a step change in our knowledge, almost all of them came from discovery science that's driven by the curiosity of the investigator and just driving that collaborative spirit to a new level. I'm sure that there will be pioneering breakthroughs in immunology, in cancer, in diabetes, and many other disciplines for decades and decades and decades to come.
I'm looking forward to being neighbors with some of my colleagues that work on what's called cancer immunology. We work on basically the same problem, it's just the opposite end of the spectrum. In cancer immunology, there's been major breakthrough in drugs that take the brakes off of T cells and lets them kill tumors. What we're trying to do is basically the opposite, is find the brakes to put on T cells. Where we are right now is we realize that many of these brakes and accelerators are exactly the same switches. What's unique about the new building is the typical way that we've organized people over the years is put all the cancer people in one place, put all the diabetes people in a different place, but now to have them together working on the same mechanism but in different aspects, that's what's going to be amazing.
Our faculty, who are extraordinarily creative, really deserve the very best environment in which to work. And this building is essentially the physical manifestation of what makes UCSF great. The opportunity to have an environment at Parnassus that supports basic science and connects those basic scientists with clinical scientists is really an extraordinary way to bring our work from bench to bedside. What excites me most about the building is the role that the faculty have played in crafting a building that is going to meet their needs. And they've really come together as a community, deciding how to bring people together, forming those really vibrant neighborhoods that are going to make their work come alive.
We're excited to move into the BRAD building for the School of Nursing. It not only links us through a bridge to the clinical side and the hospital, it also connects us to other scientists in multiple disciplines. This is going to offer the opportunity for our students who are training in science and clinical work to really collaborate. I know from my own experience as an alumni here, coming here as a nurse, I got exposed to so many other disciplines. Basic sciences, clinical science, policy makers. That really added to my whole educational experience, and that is a wonderful opportunity.
A big thing at the Parnassus campus has been a forward vision of the future of medicine, and now you can see it. When I look at that building, I say, there's going to be some new exciting ideas coming out of that building. And it has been amazing to watch it all go up. It's really been the last 6 months that we've seen all the girders go up, and now it feels real, it feels tangible. So I think right now in our department and in my lab, we really can feel that palpable energy about some change coming that's going to be for the good.
This Parnassus Heights initiative also includes the new UCSF Health Helen-Diller Hospital, which continues to take shape. In fact, the first pieces of structural steel will be laid this month. Set to open in 2030, the hospital will increase the capacity and offer world-class translational research in fields such as neurosurgery, cardiology, emergency medicine, transplant, and so many others. It will incorporate groundbreaking technologies across diagnostic imaging, robotics, and surgery. Across the Bay, the $1.6 billion modernization of the UCSF Benioff Children's Hospital Oakland campus has also begun. This will include the construction of a new hospital tower to ensure that the future generations of children throughout the Bay Area have access to cutting-edge, research-backed care in a healing environment. The project will add an incremental 104 inpatient beds and a much-needed 20-bed inpatient behavioral health unit. This effort recently received a $100 million boost in the form of a matching gift from Mark and Len Benioff. In August, just about half a mile south of where you're sitting right now, we broke ground on our new clinical and life science building at the Dogpatch Power Station development. This 300,000 square foot facility will expand our research and clinical capabilities. The building will house a center of proton beam therapy, a highly precise treatment for complex cancers that is currently available only in 2 other places in the Western United States. The building will also house one of the largest academic life science incubators for startup companies coming out of UCSF. The incubator will benefit from the proximity to this research campus, enabling startup companies to collaborate directly with our scientists and access our research infrastructure. As you saw in the video, the BRAB on the Parnassus campus is a testament to the power of how intentional investment in our spaces can drive collaboration and discovery. And at a time when higher education is under greater scrutiny, it is essential that we also show how that investment translates into impact through the success of our graduates. We continue to prioritize opportunities that strengthen how we educate and prepare the next generation of health professionals, scientists, and scholars, ensuring that trust in science and scholarship is earned anew each and every day. Across our schools, UCSF is investing in how we educate and prepare learners for a rapidly changing landscape. For example, the School of Nursing welcomed its first cohort in the Doctor of Nursing practice pathway, which recognizes the need for nurse learners and scientists in advancing health. The School of Dentistry recently received a $1.8 million grant from the state of California to launch the Doctor of Dental Surgery Advocacy, Science and Public Interest and Research, to train dental students to serve the state's underserved population. And the School of Pharmacy's Master of Science program in Artificial Intelligence and Computational Drug Discovery and Development is the first program of its kind in the United States. University-wide, we are equipping our educators, staff, and learners with the expertise to integrate AI into every facet of what we do. In the next session, the deans will share how we are preparing learners not just to adapt to change, but to lead it through investments in innovation and emerging technologies. These investments, along with our culture of collaboration and excellence, are what makes breakthroughs possible here at UCSF. And now no one better represents the kind of impact that these efforts make possible than our next speaker, Dr. Stephen Hauser. When we gathered last year, we had just celebrated the international recognition after Steve was awarded the 2025 Breakthrough Prize in Life Sciences. His groundbreaking work identifying B cells as the primary driver of multiple sclerosis overturned decades of scientific consensus and fundamentally transformed the care of patients worldwide. Dr. Hauser is a pioneering neuroimmunologist, professor of neurology, and director of the UCSF Weill Institute for Neurosciences. It is an honor to bring him on stage to share some of his groundbreaking research with you. Stephen.
Thank you, Sam. Thank you. Thanks very much. In the next 30 minutes or so, I'd like to tell you about multiple sclerosis and a personal journey. As everyone here knows, multiple sclerosis is an autoimmune disease of the central nervous system. Inflammation attacks particularly the myelin-rich white matter of the central nervous system, the brain, and the spinal cord. For people with MS, there's an attack of inflammation, a burst of inflammation, often in multiple places, about every 6 weeks. But people only experience attacks about once every 9 months or so. Almost 90% of these bursts are without symptoms or with minor symptoms. Our patients don't feel well, but our neurologic exams are unchanged. We don't use so much of our brain. But over time, these inflammations lead to important neurodegeneration. All of us, beginning at age 20, are losing about 1 million brain cells every day. Fortunately, we have 86 billion that we start with at age 20. But in people with MS, the accelerated loss is 3 to 4 times higher. And prior to recent advances, MS was, apart from accidents, the most important disabler of young adults in the Western world. And for reasons that were unexplained, but were and still are apparent to everyone, for some reason this illness seems to often target some of the most promising and appealing young adults that we're in contact with. In the 1970s, when I was training, Jacqueline Dupré was one of those young people. She is the famous cellist, a genius. It was said, as you'll see, that she and the cello became a single organism. It was natural, but also due to hard work, but much of her genius came naturally. Here is a performance from the early 1970s, right before MS began. It was mesmerizing as an artist. 2 years later, she was diagnosed with multiple sclerosis, and 15 years later, completely disabled. And that was the case for multiple sclerosis in the 1970s. On average, 15 to 16 years after diagnosis, progressive neurodegeneration led to a wheelchair-dependent state or worse. Imagine if the disease begins at age 17, by age 32 or 33, one is disabled. So for me, the interest in the immune system in the brain came from early life experiences. These diseases were all around me when I was a child, but I didn't have a direction until I met a very special patient named Andrea. She was beautiful inside and outside, an athlete, Harvard Law School graduate, and in the late 1970s, she was working in the West Wing of the Carter White House. Her judgment was impeccable until something happened. She became inappropriate, chatty, less direct in the way she was communicating with people. Previously, she was bedrock. A psychiatric disease was suspected because her neurologic exam was completely normal. She flew up to Boston, and we were able to confirm that her exam was normal, and it was decided to place her in a small psychiatric facility just to let things percolate and see what would happen. And we thought it would declare itself over time, and we'd find out what was going on. Well, anyway, 2 weeks after she began a stay at this facility, the team walked in on morning rounds, and she was slurring her speech and then developed very rapidly a right hemiparesis, right hemiplegia, and difficulty with her secretions. Obviously, this was a horrific neurologic problem. She was flown back up to Boston, and I remember opening the curtain in the emergency room, seeing Andrea in bed with her parents, her fiance, and thinking this was the most unfair thing I'd ever seen in medicine. And that's what focused me on a 55-year path to try to help advance the field. And as Sam Hawgood said, the key insight was the discovery that a type of lymphocyte called a B cell was at the center of orchestrating immune damage in multiple sclerosis. And then from that insight, developing therapeutics that targeted B cells selectively and could be administered safely over long periods of time, transforming the long-term course of the disease. And this was work that, of course, hundreds of people were responsible for. Now, you know about the immune system. Lymphocytes are the most selective actors in the immune system. They are T cells predominantly, and about 10% of lymphocytes are B cells. T cells kill cells directly, We thought that B cells were pretty unimportant. They had just been discovered in 1969. And we thought that B cells were just on the path to making plasma cells that made antibodies, these chemical bullets that selectively would kill foreign invaders and hopefully cancers. Now, B cells and T cells also, as you know, are selective because their antigen surface receptors reorganize during development. And from just 4 gene segments, each can have, by the B cell receptor or T cell receptor, tens of millions of different structures that recognize selective targets. It's very important that lymphocytes be educated. B cells are educated mostly in the bone marrow. And education selects highly active B cells that are able to see foreign invaders in the environment, tissues that shouldn't be there in our bodies, but also removes those surface receptor-bearing cells that attack our normal tissue. Now, just like with our kids and grandkids, education is most effective early in life. And what has happened over the course of the last 10,000 years as we've moved away from being hunter-gatherers, walking in packs of 10 or 20, to farmers and to have animals living with us, and then especially over the last 100 years, we have moved into these large cities with millions of people. Sam was in a tin can yesterday, breathing the air of several hundred other people at 35,000 feet. And the relationship between our bodies and the organisms in our environment has changed. With a focus on health and hygiene, some organisms result in later exposures than we had previously had during the 180,000 previous years of human existence. So we're exposed at different times, and the immune system, sculpted to the older environment, now is less able to handle this new environment. And the end result is that more lymphocytes that are reactive against self-tissue escape into the bloodstream and are not deleted. And this is probably part of the explanation for the increase in many autoimmune diseases in modern societies, and certainly multiple sclerosis. But we knew none of this 50 years ago. Those of you who remember being on the neurology services, we would place patients who we thought might have multiple sclerosis in a hot tub and see if their symptoms worsened because of disconnection. And we say, well, that's due to demyelination, and it likely is multiple sclerosis. We would do spinal taps, look at them on the neurology floors. And if the spinal fluid showed elevated levels of very specific immunoglobulin clones, oligoclonal immunoglobulins, we'd say that that is likely to be multiple sclerosis. But we were also taught that those immunoglobulins had nothing to do with the disease, that they were just biomarkers, and that T cells were responsible for MS exclusively. So why did we think that? Well, it was because of the wonderful advances in mouse immunology in the mid-20th century. So the development of inbred strains of mice made it possible to transplant different tissues from one mouse to another so that one could see which elements of the immune response were responsible. And there is a model in animals where one injects small pieces of brain tissue or myelin or specific myelin proteins under the skin with an adjuvant, with an immune stimulant. And that then causes brain inflammation. And when one would dissect out that brain inflammation in the mouse, you could put in T cells or B cells or any other type of cell to see which which cell in the ill mouse could transfer disease to a healthy littermate that was genetically identical, because they accepted each other's transplants. It was very clear that T cells were necessary and sufficient to cause brain inflammation, i.e. T cells cause multiple sclerosis. And every young neuroimmunologist would cut his or her teeth on this model called EAE. But the amazing thing about it, and perhaps the key driver insight, which was a clinical insight, was that the pathology didn't resemble human multiple sclerosis at all. Well, of course not. These are tiny mice with small brains. But they also have 23,000 genes, about 1,000 base pairs each, just like us. So looking in the literature, and this was, again, a long time ago in the 1980s, it became clear that there were some descriptions from the early vaccine neurologic events that would occur that brain inflammation that looked much like MS could happen in monkeys that were immunized with human brain tissue. So I thought it would be important to see if there was a model in a species phylogenetically closer to humans that we could look at to investigate the pathology. And there was, and a classmate, Norm Letvin, who's passed, who was head of the immunology division at the New England Primate Center at Harvard, introduced me to the marmoset New World monkeys. These are small animals about the size of a guinea pig. They weigh 400 grams, and they're immunologically unique because they're born as multiple births. They're not identical. They're non-identical triplets, usually, that share a common fetal blood supply. And this should make the kind of transplant that was possible in an inbred mouse now possible in an animal that was closer to human. So we set out to build an immunologic toolbox that would help us begin to do these kinds of experiments in mice. But then the problem with this little animal was that, try as we might, they seemed to be entirely resistant to brain inflammation. So the next part of the story is that a young neurologist sent to work in my laboratory from Florence, named Luca Massachesi, came to work on this model. And I said, Luca, we just can't do this. We've been trying for years. We can't make the animal sick. You have to have a project that works. We need to do something else. And he said, Steve, give me one chance. I have an idea. And Luca changed the adjuvant to a novel, less intense adjuvant. And 3 weeks later, we were called up, and one animal had double vision, one animal had a little bit of incoordination in one arm. They got better. They then had new attacks. They got better again and again, and then both developed slow progressive disease. And most important, when we looked at the tissue, it was absolutely identical to human MS. So we had drunk the Kool-Aid. We thought that MS was a T-cell disease. And we then spent 3 years transferring every type of T-cell clone and T-cell population into unimmunized animals and kept seeing the mouse inflammation, but never the MS inflammation. A second young postdoctoral fellow at UCSF, Claude Genane, was beginning to work in the lab. We were on a boat on the way to an MS Society event, trying to understand why this wasn't working. And he said, maybe it's not T cells at all. Maybe it's B cells and antibodies. This was anathema in the neuroimmunology field. But we ran back, and within 3 weeks, we replicated the disease by transferring B cells and antibodies into an unimmunized animal. Now, we could have conjured up a pathology that looked like MS, but was just a phenocopy. So then we needed to go back to the real MS tissue. And as everybody knows, the importance of human pathology is as urgent today for discovery in the neurosciences as ever before. And when we went back to the human pathology for the first time, we were able to see B cells and antibodies embedded in degenerating myelin membranes and on degenerating nerve cells. So this was now 1998. It was the dawn of the biotech era. And the first monoclonal antibody, rituximab, everyone knows about rituximab, had been cloned by a small company in San Diego called IDEC Pharmaceuticals. Bill Rastetter was the CEO of IDEC. You can't make this up. He was also my college roommate. And amazingly, the first human monoclonal antibody was against malignant B cells used to treat lymphoma, approved in 1997. IDEC was a small company and needed to have a larger biotech with more funding to do the clinical trials, so they partnered with Genentech. So as an academic, what we all do is we pull together a consortium, write a grant to the NIH, and say we would like to test this novel hypothesis that B-cell therapy might be helpful for people with MS. And you all know when you write a grant to the NIH, you wait, and then you wait, and then you wait, and wait a little bit longer. But we were pretty confident. The basic science was airtight. And we got back, what in those days were pink sheets, and it said, biologically implausible. And then I got a call from the head of the Neurologic Institute. And he said, you've put together a great group. Give up this B-cell nonsense and find a treatment against T cells, and we will fund you through the NIH. Now, I can't blame the NIH. They're reliant on expert opinions, and if they weren't, lots of crazy ideas would be funded. But the high-risk kind of work can fall through the cracks, as Sam said earlier. So, fortunately, Genentech is a UCSF company. It began with UCSF and Stanford scientists. So we went down to, beginning in 2001, to Genentech to argue for this idea. Could we use rituximab as a test case to see if it would benefit people? And it took 18 months of going back and forth with they have a Merlin organization that predicts if something will work, and it was less than 15%. The advisors were against it for the most part. But then at a final meeting in 2003, we were all there together talking about the risks and the benefits, and Art Levinson, whose daughter is was in Sam's department and still is a UCSF faculty member, Art Levinson stood up and said, for goodness sakes, if we don't do this, why are we in business in the first place? That broke the logjam. We went to the FDA, who said, you're going to make people sick. Because in the mouse model, if you get rid of B cells, the mice get worse, because B cells were suppressing, their regulatory B cells were suppressing the immune response. So they said, you can't do a full trial. We'll let you give one dose and see what happens in 6 months. Now, at the time, we still didn't understand. I'll show you at the very end how we think B cells work today. But we thought that antibodies were probably the key, and it would take a long time for B cells to mature into plasma cells and then make antibodies that would destroy myelin. One dose and a 6-month follow-up would not be enough. But we were hoping for just a little bit, a whiff of a benefit that could propel us to go back to the FDA for a longer study. The blind was broken on the last Friday in August 2006 at 3 o'clock in the afternoon. And what we saw was incredible. We saw essentially a complete elimination of brain inflammation in the patients who had received the single dose of rituximab. And the benefits were present even at 4 weeks, which was the first MRI scan to be sure we weren't increasing inflammation and making patients worse. I remember the woman who worked arm in arm with me at Genentech. Her neck was really on the line with this, and she broke out crying, a mixture of relief, happiness, and the end of pressure. So I thought that everything would be smooth from here, but that wasn't the case. The FDA said that we had to do dose-finding studies, which would delay things further. Fortunately, the immunology team at Genentech, led by Andy Chan, I don't know if Andy is here, who won a Distinguished Alumni Award 2 years ago at UCSF. Andy was developing a B-cell targeted monoclonal antibody called ocrelizumab that had much more favorable characteristics, less mouse protein, killed in a more attractive way, so we could use it over chronic rather than acute use. Genentech was purchased by Roche. Roche is a conservative Swiss company. I was confident that we were in trouble because of their conservative nature. And the problem was that rituximab, as the first monoclonal antibody, was also too inexpensive to justify an $800 million investment in pivotal clinical trials. But Roche, the minute that contract was signed, the ink was still wet, they green-lighted the MS program because they felt a moral obligation to do that. And that's been my experience with industry throughout. So we did the ocrelizumab trials, and I'd like to show you the current data with ocrelizumab, which is a B-cell targeting anti-CD20 therapeutic for multiple sclerosis. This was the pivotal trial with the extension. And as patients with MS come into the study, and you can see on average as they come in, they have about 2 spots of acute inflammation on MRI scan at the time they come in. Using the comparator treatment, which is an immunomodulatory drug, a type 1 interferon beta 1A, there's a reduction by about 75%, not bad. But with the B-cell therapy, the reduction is greater than 99%. And over the course of 12 years in the open label extension, the safety and efficacy remain sustained. Patients who were in this study originally have fewer than 1 attack per lifetime and are on average neurologically better 12 years later than they were originally. This led to other follow-on anti-CD20 drugs, ofatumumab by Novartis, ublituximab, rituximab is still being used, and today more than 1 million people with multiple sclerosis are receiving these therapies. And you can see the open label extension here. After 2 years, patients were put on the active drug. And relapse rates also fall commensurate. So I think that these studies show us that although the rubber hits the road when we're testing our ideas in the clinic, we learn things from the clinical experience that we can take back to the laboratory. And it's when these two environments merge together that the most accelerated progress happens. And that certainly is the case for the MS story. To see an immediate reduction of inflammation and relapse activity meant that antibodies were not the major part of the story. Something else was going on. And we used to think of B cells simplistically as just way stations on the way to plasma cells that were antibody-producing cells. We know now that that is not at all the case. So B cells have many different functions. They secrete cytokines that can amplify or suppress immunity. Genetically, people with MS and some autoimmune diseases are polarized to have B cells that are secreting pro-inflammatory cytokines more than others, particularly tumor necrosis factor, which is an especially neurotoxic molecule for all neurodegenerative diseases. I'll say a word about Epstein-Barr virus. I mentioned it earlier. EBV is a ubiquitous virus. 95% of us have Epstein-Barr virus in our system, but only in people with MS does Epstein-Barr virus appear to have a particular deleterious role on the pathway to developing disease. So the 5% of the world who don't have Epstein-Barr virus infection never develop MS. And when we have MS, especially when we get it later in life, we tend to have a disease called infectious mononucleosis. We recover from infectious mononucleosis, but Epstein-Barr virus lives in all of our bodies for the rest of our lives. And it lives in just one place, in B cells. And we think that Epstein-Barr virus is necessary, but probably not sufficient to trigger multiple sclerosis, and that the mechanism is most likely the antigen-presenting role of B cells. So B cells, in addition to making antibodies and secreting cytokines, presents antigen fragments to T cells and can activate a variety of other immune cells in the nervous system. So they are truly the generals of immunity where MS is concerned. B cells, you can see in blue, have this B cell receptor that can trap antigen fragments and protein fragments. Through the endosome, they are broken up, and then they are presented to T cells, which you can see in purple here. This stopped. You can see the T cells in purple, and I'll just stop there and tell you one thing about this relationship. So T cells through the T cell receptor sees B cells that captured antigen on their B cell receptor but are presenting antigen on their HLA molecule. There are about 1,000 different HLA molecules. People with MS tend to have one called DRB1 start 1501. It's a class 2 MHC molecule that is particularly effective at triggering this process. And what is the antigen that's being presented? Well, amazingly, it seems to be a fragment of the HLA molecule itself, which then is cross-reactive through molecular mimicry when recognized by T cells with a variety of other proteins, including proteins of Epstein-Barr virus and proteins of myelin. And finally, infected cells, Epstein-Barr virus infected B cells, can have an Epstein-Barr virus protein that takes the place of one of the co-stimulatory molecules, pushing towards a pro-inflammatory T cell response. So there is so much more to be learned, and I think that's why for Someone like me, I'm still at it years after I thought my expiration date should have been reached. A whole new generation of more selective B-cell therapies are in the pipeline. Very exciting results presented in Chicago just on Wednesday. An understanding that the earlier we treat, the more effective our therapy is against late degeneration. An understanding of a new pathology of MS, where after a period of time, other cells, and especially a cell called the microglial cell, probably activated by B cells initially, but now operating independently, are triggering disease in patients with late-stage MS that are not responsive to drug. And the development at UCSF, and Mark Anderson is one of the developers, who, Mark, you saw earlier on the video, of platforms that let us begin to predict who is at special risk for MS. And this would let us treat even earlier, potentially. What if we could eliminate Epstein-Barr virus in patients at particularly high risk? So I'll close and would just maybe say a couple of lessons that come from this. The first is the critical importance of physician scientists who are walking the walk on a daily basis between the laboratory and the clinic, and the international community that is essential and part of our DNA. And the second is that academic medical centers like UCSF are national, global treasures by bringing together basic science, clinical science, and patients. By having open doors to industry and creative new ways of interacting with industry, I'm very confident that although MS is one of the early neurodegenerative diseases to be effectively treated, that with the kind of infrastructure that we now have and the far better animal models that we have today that are incredibly exciting, where we can bring human cells from disease into test tubes, iPSC, stem cell technology, organoid technology, that we can see accelerated discoveries against these terrible neurodegenerative diseases if we have the will to support and nurture this climate. Remember that less than 0.5% of the healthcare budget goes today towards medical research. This discovery would never have happened were I not at UCSF. And then finally, I would say that I've now been leading an attempt through the Weil Institute to integrate neurosciences even more broadly across our campus and with other campuses. And I've retired as chair of neurology now for 8 years. My successor, Andy Josephson, some of you know Andy, is an amazing chair, an amazing builder. Neurology has grown dramatically. Our patient services have grown dramatically, except the MS service. It's the only service that hasn't grown in neurology. General practitioners are now comfortable caring for people with MS. They need an infusion every 6 months or an injection every 6 months or a self-administered injection once a month. Our beepers or phones now aren't going off Friday evening because patients are having attacks. And really, that is what this is all about. Reducing the burden of terrible diseases and putting ourselves out of business. So thank you all very much.
Thank you, Steve, for sharing your incredible personal journey and getting Alumni Weekend off to such an inspiring start. Just an amazing story. And as you said, UCSF and all that we have built, all that you have helped build over so many decades results in this kind of amazing story. So thank you all. The next session will start here at 11 o'clock, which is a conversation with our deans, not to be missed. I know how exciting they can be. And between now and 11, there's coffee and refreshments just outside in the lobby. Thank you again.